Nivolumab was approved in 2015 for the treatment of metastatic kidney cancer patient progressing after traditional anti-angiogenic therapy, showing actually an overall survival benefit over everolimus with a very good quality of life scores and benefit. And we know from the melanoma literature that combining both nivolumab and ipilimumab, another tumors that to some extent responded to cytokine like renal cell in the past, melanoma. We know that the combination of a CTLA-4 like ipilimumab and nivolumab PD-1 inhibitor result in higher response rate. So this was investigated initially as part of a phase 1 study of 3 cohorts, have 3 different doses. Nivolumab 1 mg per kg, with ipi 3 mg per kg, or nivolumab 3 mg per kg, ipilimumab 1 mg per kg, or actually nivolumab 3, ipi 3. The higher dose in both the drugs was the cohort was aborted for toxicity. And then when nivolumab N3 ipi1 was compared to N1 ipi3, the response rate was high, was between 40 and 45%. Higher than historical responses with nivolumab, though it's around 20 to 25%. It's not head-to-head, but it was higher. The toxicities with higher doses of ipilimumab were higher. So finally, the regimen of nivolumab 3 with a lower dose of ipilimumab was taken to the next stage toward a phase 3 trial, a large phase 3 trial called Checkmate 014, Checkmate 14, that compared nivolumab plus ipilimumab combination to sunitinib. Sunitinib, again, being the standard, the most used drug, widely used drug in metastatic kidney cancer. Interesting design because the study focused on intermediate and poor risk, and that's justifiable. These are the patients that need the most, treatment. And the study had 3 endpoints. So the alpha anyway was split. 3 endpoints: response rate, PFS, and OS. So 3 co-primary endpoints. And the study actually met 2 out of the 3. Response rate were higher with nivolumab and ipilimumab, 42% compared to 27% with sunitinib. So same response rate actually as the phase 1. And the overall survival was higher with the combination, with a hazard ratio of 0.6 compared to sunitinib. Now the progression-free survival numerically was higher, but it didn't meet the pre-specified p-value for at least statistical significance. So this regimen is expected to be FDA approved soon. There were more toxicities on the nivolumab plus ipilimumab, leading to more treatment discontinuation than sunitinib. And the toxicities usually are immune-related adverse event, to a degree that 60% of patients needed a steroid use. But certainly this is the first time we witness that a combination immunotherapy in kidney cancer could be better than a sunitinib, a VEGF, tyrosine kinase inhibitor, and anti-angiogenic agent.